On average, residents living in congregated settings have a lower quality of life, and that's reaffirmed in your reports. Regrettably, your inspections have showed poor compliance results in poor quality of life for residents or impacts on safety. Your findings are even more worrying when we consider the slow rates at which individuals are moved out to community settings. I'm deeply concerned at the increased use of private providers for vital health and social care services, and for the use of congregated settings as the default situation when the state fails to provide the necessary support. I'm continually highlighting the over 1,300 people under 65 confined to nursing homes as an example. Not only is current policy breaching their rights, it's harmful to their quality of life and future prospects. It's important to note, I think, as well, that you found considerable compliance and instances of good practices with adults and children having positive experiences. However, it's the non-compliance and harmful activities that is important for us to focus on. The report shows how in organisations where there was limited provision for independent choice or self-advocacy, residents were more likely to express dissatisfaction. Inspectors were informed by disabled people were not being listened to, or that their rights, privacy and dignity were not being respected. Could you elaborate on that point and the impact that it has on individuals? Inspectors found that in some cases, care providers were not ensuring that residents could directly access their own money. This is an extremely worrying. Not only is it disrespectful, it's potentially abusive and illegal behaviour. While some issues regarding agency can be there's grey areas, this is a black and white matter. So I'm just wondering if you can explain more about these situations and the actions that you took, and can you actually compel those providers to stop those kind of malpractices? Another worrying finding is that some children didn't have a school placement or an individual education plan, and you cite a case where a child was not being provided with their right to education. Again, that's a serious issue bordering on neglect and illegality. What can you do in those circumstances? A very serious finding is that not all had been afforded or accessed in terms of national health screening services. That's frankly disgraceful and neglectful, running the risk of vulnerable people developing serious conditions. Given the significance of that finding, I'm wondering what actions were taken. And while the overall provision of assessment and care planning is good, there were cases of individuals not having their full care and support needs adequately assessed. And this obviously impacts on their quality of life and risks different forms of regression. Could you outline the recommendations you make regarding assessment compliance and the provision of personal planning processes? Thank you.
Thank you very much, Holly. Carol.
Thank you for your questions. I think in relation to residents having access to their own money, it's a fundamental right. And I think a huge amount of progress has been made since we started regulating in this area. And what we have seen is that some providers have supported residents to be able to take control and spend their money as they see fit, and other providers have been slower. And it's a key focus of our rights-based approach, no more than any other right that we look at, such as privacy and the right to your own space and the right to live in a safe environment. The right to have control over your own possessions, which includes money, is a key right. If I maybe just talk generally, and then the actions that we can take in relation to where providers aren't meeting those required standards. Again, I think the capacity legislation that's due to the decision-making capacity legislation will really support residents in this regard across the board in terms of upholding their rights, in terms of ensuring that capacity is not, or a lack of capacity is not presumed, and presumed to be a lack of constantly, but constantly reviewed. And I think that understanding the will and preference of people and taking that on board where there is a lack of capacity. So I think it's hugely essential that that legislation is commenced as soon as possible. I think also a key area here is the lack of safeguarding legislation. While there is regulations around safeguarding, they don't really go far enough to protect vulnerable adults, and the safeguarding legislation would very nicely work alongside the regulations to further safeguard residents in the case of control over their own possessions, control over their choices, and their will and preference. In relation to where a provider doesn't have, or where we've called out certain examples of where providers have failed to uphold the correct standard and indeed move beyond the basic requirements, such as the child that didn't have a school place or residents who didn't have access to health services, we assess the risk and the impact to the residents. We require the provider to submit to us a compliance plan of how they're going to address that issue. In some cases, we will direct the provider on the day of the inspection if the impact is so significant, and we call that an urgent action plan or an urgent compliance plan. And if we believe that the risk is significant, we will set the time frame by which the provider must comply. And then we monitor that. So we may go back out and inspect. We may require the provider to submit an update on their progress against those action plans. And I'll ask Finbar maybe to give more detail on this. If we find it's a trend of a provider in a number of centres, then that provider will be brought in to speak with us, and we will talk to them about the areas that are cropping up across their services. And I'll ask Finbar to give you more detail on that. I suppose the other area is in relation to, and you quite rightly point out that in congregated settings that there is a higher prevalence of non-compliance. And, you know, we have, I suppose, outlined in both this report and in previous reports about the importance of transitioning people to community-based settings. But the ethos of the care and support has to change in that move to the community-based settings. So there has to be, you know, a different approach to the support so that it is more community-based, it is more inclusive. The residents are involved in the decisions. And in the report that we published on Tuesday, there is examples of where the residents identified where providers have a much more inclusive way of running a service where residents are part and parcel of that, and where other providers are not quite there yet. And that's going to be a focus for us going forward. Residents' rights and the residents' positive behaviour support and healthcare, they're all key aspects of every inspection that we do. So it's across the board, we will look at them. But none of them can be looked at in isolation, because one regulation will always impact on another regulation. So as Ciara outlined earlier, you know, non-compliance with premises will have a huge impact on the rights of residents and the privacy of residents. I'll ask Finbar maybe to highlight what, in relation to both from a quality improvement perspective, but also where providers are not meeting the required standards, the actions we've taken at a provider level.
Okay, Finbar.
Thanks, Carol. I suppose the first comment I would make is that, as referred to earlier on, we did find that most services were good services, and while that might be a trite term, it actually does reflect, and I think it's important that we recognise that there are many providers that are operating very good services. We may use language like good standard or whatever, but the implication of that is that they are actually listening to residents and providing a good service, and I think it's important to recognise that. There are a cohort of providers and a cohort of services where regulation provides protection to residents, and it's required protection. We call out issues, we name them, and that's why they're in the report, because the providers need to be held to account, but also we share that information so other providers can be aware of risk. In relation to providers where we have a trend emerging, so if we have across a number of services, we identify that similar issues are rising. there's a failure to have shared learning amongst the provider centres. We see that as a governance issue at organisational level. And while the regulations require us to look at centre level, we do engage with providers at organisational level. So in quite a number of situations, including quite recently, we have brought providers in to meet with us. We have told them that we are very concerned about the effectiveness of their own monitoring and surveillance of their centres, that they're not identifying where things go wrong and are not responding themselves. We do that at board level. So we call in the board or representatives of the board of the organisation. Normally those board members will bring senior executives with them. In those situations, what we have used is what we would call an escalated regulatory programme. So we require them to review their governance arrangements and the effectiveness of the governance arrangements across all of their services. We require them to give us an improvement plan within a short period of time. We then require them to implement that over a defined period, normally 6 months. During that 6 months period, we undertake sampling inspections across a range of their centres to effectively to look at how effective their actions are. So sometimes providers give us an action that looks reasonable, but when we go out on the ground, actually, while that action is being implemented, it's only seen at senior levels and it's not impacting on the lives of residents. So we will challenge providers on that. We'll challenge them to link in with their residents to hear the views of the residents as part of that process. And at the end of that 6 months, we will look then at the effectiveness of the programme, whether we can find the provider to be fit, whether their actions have impacted on the quality of residents. And we've undertaken those programmes with a number of organisations at this point.
Okay.
Can I just ask, in relation to, Carol, you spoke about the kind of on the financial abuse piece and the kind of the welcoming of this Assisted Decision-Making Capacity Act, and I think everyone does, we needed legislation around that. But like all of us would know, it was very rushed through the houses here, and we were told that there was a timeline we definitely had to meet, and then it turned out that we didn't have to meet that, but all of the kind of amendment stages and everything of that were rushed. And within the legislation now, there still remains a thing called the I think it's called the functional test of mental capacity, and that's been found to kind of discriminate against people with disabilities. And one of the key findings around that was that depending on who carries out the test, there's a different result. So it kind of shouldn't be used. However, it still will be under Irish legislation here. And then in addition to that, because you spoke about the kind of importance of presuming capacity, and that was the entire purpose of that legislation, but then in the codes of practice that go with this, that weren't, as far as we can gather as a committee, there wasn't that much engagement with DPOs on these codes of practice or anything like that. And ultimately, it outlines that, for example, a bank manager can decide that you don't have capacity. So the codes of practice kind of fly in the face of the entire purpose of the legislation. So I just wanted to know if you had any concerns about it, and that's not necessarily something that you look into. I'm just curious to know if there is anything. And then in relation to a case that you spoke about, Carol, where you might go somewhere and there's an urgent compliance plan put in place, I'm just wondering, is there an example of what kind of a situation would result in that urgent compliance plan?
Thanks very much.
Okay.
Holly.
In relation to the capacity legislation, as I said, I think it will support. It won't take away from what we do, where we go in and where we ensure that residents are consulted with and included. And there's lots of ways of including residents, and there's lots of ways of including people who may not have capacity. So we will continue through our regulations to ensure, I suppose what it is looking at how all of this comes together. So, if you have safeguarding legislation along with our legislation and potentially, hopefully, reform of our legislation and updated regulations, hopefully in the near future, along with the capacity legislation, that all of it works together to better support the person and to better support that person being able to articulate their rights and to live their life. I think one of the quotes that sticks into my head from the report from Tuesday is, "I have the same rights as everybody else." And I think it's such a strong statement to make. And I think if we keep that at the fore of everything that we do, I think all of the legislation and supports then can better support the person